Another portion of my practice that I do a lot of is something called microtia. And what microtia is an absence of the ear or a smaller abnormal looking ear. What happens at around the 5th to 12th week of gestation as the fetus is first forming, there's an artery called the stapedial artery, which is an embryonic artery that it is theorized that artery goes away, thrombosis, or is absent. Because there's a lack of blood supply in that area, there are certain structures that are forming during that time, specifically the jaw, some of the soft tissue of the face, the ear, and some other structures as relates to that. Microtia is, again, an abnormal ear. With regards to the classification of microtia, there's several different classifications, but basically, to say it simply, there can be a small ear where all the structures are present. There is some of the structures are absent, or there is just one of the structures, like for instance the earlobe, or the ear is completely gone. The most common thing that I see is that third variant. It's called grade 3 microtia, where just the earlobe is present, and I'll show you a picture of that. But if you look at this child has either grade 3 or grade 2 microtia. So what you can see is that the earlobe is formed, the conchal ball, which is the structure where the ear canal starts, is present, but the whole top half of the ear is absent. In this one right here, this is the lobular pattern microtia, which you can see is just the earlobe is present. Or you can have variants where the ear is smaller and most of the structures are there. Or you can have this where all the structures are there, the helix, the antihelix, the conchal ball, but they're a little small and they're a little abnormal. With regards to how you work this up and what's the treatment for kids with microtia, there's nothing to do, unfortunately, for the first several years of life. And the reason for that is that the ear has to grow. The ear is 80% of adult size at around age 6, and it is 95% of adult size by age 8. So with regards to making an ear, you want to time it with regards to when the child's ear is more of adult size so that they're matching. There are 3 techniques with regards to making an ear. So a child presents with microtia, and we're watching that child for a little while. And there's certain syndromes that are associated with microtia that we'll talk about. But with regards to making the external ear, there are 3 techniques. The first of which is called an autologous rib graft microtia reconstruction. With autologous rib graft microtia reconstruction, what you do is around age 6, you make a small incision in the right chest, just below the breast. You go down and take portions of 3 of the ribs. And after you take those, you then shape them into what would be the ear construct. So you would make the helix and the antihelix, and you would bury it under a pocket underneath the skin. And then you would allow that to heal. And then you come back for 2 or 3 additional surgeries where you then elevate that construct, skin graft behind the construct, rotate the earlobe, and then create what would be the normal ear. And we can show some before and after pictures of that. Alternatively, if the rib graft reconstruction is something that the parents aren't interested in, you can do something called a Medpor implant reconstruction. And what a Medpor implant reconstruction is there's a piece of plastic that looks just like an ear. It's the helix, it's the antihelix, and it's the tragus, which is this structure right here. You can take that construct, put it right where the ear would be, and then lift some tissue underneath the scalp, which is called the temporoparietal fascia, cover the ear, and then skin graft that. And those look fantastic. The problem with that is that the complication rate is a little bit high. About 5 to 10 to 20% of these kids will have some exposure of that ear, of the construct. And if the construct's exposed, it's very difficult to salvage that operation. The ears are questionably a little bit more defined, a little bit more aesthetically ideal with the Medpor implant reconstruction. The problem is that if the Medpor reconstruction doesn't work, you can't go back and do the rib graft reconstruction. If you do the rib graft reconstruction first and there's a problem, you could always go and do the Medpor reconstruction, but you can't go back. Lastly, what you can do is something called a prosthesis. And with a prosthesis is you put a little metal post with a magnet right in the bone, which is the mastoid bone back here, and then a prosthetist will make a fake ear, which looks identical to the contralateral ear, and it would just click on. And those work great. The morbidity of that is very low. The problem is that you have to make it. These are children. They click on and off. You can lose them. They chip, fade, and you have to replace them. The first 2 options are more permanent, and it's something that would be with the person for the rest of their life. And those are your 3 options with regards to microtia reconstruction. Things to look out for in kids with microtia. Again, as I said, the ear is forming the same time as the jaw is forming, as some of the soft tissue and the nerves are forming in the face. And there's a condition called hemifacial microsomia. And hemifacial microsomia is basically a constellation of findings that you see in kids where they have this growth retardation. So when I see a kid with microtia, what you want to look at specifically is the growth of the jaw. Because if the jaw in a kid with microtia looks a little flat, or if the jaw is moved a little bit towards the side with the microtia, that would be consistent with a kid with hemifacial microsomia. And what you would see in that case is that as the jaw is growing, in this kid it's growing normally on this side, and everything will continue to grow this way as this side is not growing. So as they get older, 6, 7, 8, 9, 12 years of age, the jaw will be pushed over towards the side that's affected. It'll be short, and the maxilla on the affected side likewise will be canted. So they have an occlusal cant, the jaw is flat and short on that side, and they may or may not have microtia. So it's something to be aware of when you first evaluate a child with microtia. So when they first come in at 2 months and they're super concerned about the absent ear, you have to be aware that there's other things that could also be not growing quite well. So as you follow these kids over these years, you have to kind of make sure that they're involved in a comprehensive team so that all these things can be followed appropriately.